Good morning, everyone. I'm Dr. Chitra Pandya. I'm Dr. Satish Pandya's daughter. And since my father is traveling currently, I'll be handling this session on his behalf today. I take this opportunity to welcome Dr. Arif Ahmed, who is, I'll just read out a brief introduction of him from his slide. He is MD Pediatrics. He has done his MD Pediatrics from Bombay, and he has trained at the Royal Manchester Children's Hospital at UK in allergy, and has passed the European board exams conducted by EAACI, that is the European Academy of Allergy and Immunology, in 2013. He's a professor of pediatrics at Shaddan Medical College, Hyderabad, and he's also the director of Allergy Center for Allergy and Chest Diseases in Hyderabad. He has several publications on allergy in national and international journals and conferences in US and Europe. He has delivered more than 150 lectures on allergy across India, including state orations.
Okay, thanks. I think that's all.
I'll just add that he is also the author of Winning Over Allergies, Myths and Facts. I now hand over the presentation to Dr. Arif, sir. Thank you.
Thank you, Dr. Chitra, for your kind presentation. And I thank Dr. Satish Pandya for giving me this opportunity. This is not the first time or the second time, but the third time I'm getting this opportunity to address the Baroda gathering, first once physically way back in 2015 and then last year on food allergies. Now it's when I face the Baroda, it is like I face the crowd, has some mixed feelings because it's a very educated and enlightened crowd. Okay, so like I don't know which question, there's so many questions they have, okay, and very brilliant questions. So sometimes I have a problem in a difficulty in answering them, but then I go back with a lot of information also myself. So I'm really glad to be back again, and I'm really happy we have enlightened people with us, especially besides all the Baroda people, Dr. Jagdish Chanapa from Bangalore, and I'll be very happy to make this discussion a very interactive one. So can you have the next slide, please? Next. So it's basically going to be case-based management of childhood food allergies, because that way we try to bring out we make the horizon more wider, and it'll be around 6-7 cases, different type of cases in as regards food allergies. And any questions the audience may have, they may put it in the chat box for me to answer later. Next, please. So now, why there should be this discussion on this childhood allergies? The most important reason is this slide which you see in front of me is what, can you see the cursor moving? No. Okay. So it's all right. So yeah, as you see, way back in 1960, there was this, from 1960 onwards, the respiratory allergy epidemic started increasing. This is of the Western world, okay? It started increasing, and then it peaked in 1980. Why did it peak? Because of the increased use of inhalants, okay, and other respiratory medicine. And then after a 20-year lag, now what we are seeing in the West from the year 2000 onwards, that is the beginning of this century, that there is an epidemic of eczema and food allergy. Why is this so? One is because of the change in the lifestyle disorders, okay, that is more and more westernization, and have been written a new book which is coming up, Overcoming Food Allergies, where we talk about all this processed food and the change in the traditional habits increasing the food allergies. And the second and the very important thing is the food allergy test. More and more advancement in the food allergy test. Some of that I will be I'll be mentioning in my lecture through my case scenarios. So it is only a matter of time that we at this moment may be having this respiratory allergy epidemic, but it is only a matter of time that we will be seeing an epidemic of food allergies. Already we are seeing this in greater numbers in our NRI children who are coming from the Middle East, from the West, especially UK and America. I see a lot of them, and I'm sure every one of you all, most of the cases of atopic dermatitis and of food allergies must be more of NRI kids. Next one, please. So, a very clear thing which needs to be this: what is food allergy? Is a term used by many patients and clinicians to describe a variety of adverse reactions to foods. However, not all symptoms after ingestion of a specific food are due to an allergic or immunological mechanism. Next, please. So, then what is? So, there's a broad term adverse reaction to food, and food allergies is one of them. So, what is food allergy? It has to be immunological mediated. Predominantly, it is IgE mediated, and a small percentage is non-IgE mediated. So the immunologically mediated is of acute onset, immediately on ingestion, caused by the triggering food allergen, where they, and the worst form they may be anaphylaxis, and this is usually always IgE mediated. And the chronic disorders are atopic dermatitis and your eosinophilic esophagitis. And the one which are not immune mediated, which and a lot of people attribute it to food allergies, is like some examples are lactose intolerance, or due to toxin in food like bacterial food poisoning, or pharmacological effects, that is caffeine effects, or some people say I have allergy to alcohol. Okay, I mean, why? And if you test them for the particular alcohol, it may come negative. It is because of the histamine content in that particular food, especially alcohol. Okay, next, please. So, broadly, we classify the adverse reaction to food as immune mediated, non-immune mediated, and toxic. Among the immune mediated is what we refer to as food allergy, which could be IgE mediated, and which an urticaria, a rash, is almost always present. Not always necessary, but it should be there. The non-IgE mediated are the food protein induced enterocolitis syndrome, food protein induced proctocolitis, food protein induced enteropathies, which we will not get into details today, but we'll have a passing mention. And it could be the mixed IgE and mixed, non-IgE mediated. An example of this is cow's milk protein allergy. Cow's milk protein allergy could present as an IgE mediated. It could present as a non-IgE mediated. Okay, and your eosinophilic gastroenteritis. Among your non-immune mediated is the food intolerance, and which some of which I have mentioned. And then we have the toxin ones, last one. So let's next, please. So how will you in clinical practice differentiate between a food allergy and a food intolerance? Food allergy is always a reaction to an immune system. The immune system is going to play is predominantly IgE mediated. Sometimes it could be T cell, where your immune system mistakenly treat the protein in food as a threat and can be life-threatening, such as anaphylaxis. While food intolerance, the immune system is not involved. There is no allergic reaction and there is never life-threatening. Food allergy will start immediately after eating just a small amount of the food. Typical allergy symptoms such as rash, wheezing, and itching. A rash is usually present, and this one in food intolerance starts slowly after many hours after eating a reasonable amounts of the problem food. And the common foods in food allergy in adults are fish, shellfish, and nuts. In children, it is milk, eggs, and peanuts. And this last one is very important: milk, eggs, and peanuts. While in food intolerance can be caused by any food, and it could be caused by all your additives, preservatives, and the Chinese food syndrome, that is Ajinomoto, monosodium, MSD. So all these things come under the terminology of food intolerance and not food allergy. Next, please. So food aversion is a psychology of food intolerance, and here we need to do a double-blind trial, okay, and which will rule out food allergy. Food poisoning I've discussed, and food idiosyncrasy is an example is sulfite-induced asthma. Next, please. So the prevalence of food allergy in adults is 1.4 to 2.4%. These are all Western. This one we don't have much Indian data. In children less than 3 years, it is 6%. So what we see in children, there's a lot of food allergies, 6%, and by the time they come to adults, it becomes 1.4 to 2.4%. So that means a lot of food allergies outgrows. So, but we are not diagnosing so much of food allergies in children, And one of the example of that I will give to you through my case scenario. So then we have the oral allergy syndrome, in which case there may be 25 to 70% in pollen allergic patients will occur. Atopic dermatitis having concomitant food allergy will be 35%, and acute urticaria being the cause of food being a cause is 20%. Chronic urticaria, food as a cause of allergy in chronic urticaria is very rare. This is the most important point you should take, that in chronic urticaria, please do not think of food as a cause. Chronic an asthmatic child having food as a this one is very low, is as low as 6%. Okay. Well, chronic rhinitis, food being a cause is also very rare. So please, when you're testing in rhinitis, usually patients will ask, do you have any food allergies? No. Do not take the trouble of checking for foods, because it's very rare that you might find a particular food. And food allergy leading to anaphylaxis could be as high as 55%. And this whole prevalence depends on genetic factors, age, dietary habits, geography, which we are seeing the West and the Orient, and diagnostic procedures. Next, please. So let's start with this first case. We have a 10-month-old girl, is an NRI girl. She came to me with atopic dermatitis. The history is that she was bottle fed for the first month, then breastfeeding. Weaned at 6 months, strict vegetarians. She's on pulses, wheat, rice diet, vegetables and occasionally fruits. Both mother and baby of milk totally since reacted adversely in the form of severe rash and vomiting. So this child is predominantly on a vegetable diet, okay, and is not on milk. Next, please. So we did a skin prick test, and this is how the skin prick test looks like. What you see out here, that number 1 and 2, you have to see a wheal formation, and if the wheal formation is more than 3 mm, yes, it is suggestive of allergy. Next, please. Next, please. There's something called a prick test. What you can do is any fruit or any vegetable which can be pricked, you can just prick it with a lancet, and then you prick the skin, wait for 20 minutes. If you see a wheal formation more than 5 to 8 millimeters, then it is significant. But you should always have a saline control and a histamine control. Okay, it's as simple as that. Anyone can do it in their clinic. It's very safe. Okay, next, please. So these were the results in that particular child who was a 10-month NRI and off milk. What you see is out here is a peanut. Okay, it's now the whole thing is, when you see out here, how do you interpret it? It's a very simple way of interpreting it. Anything which you see is in the skin prick test is more than 8 mm, it is allergic. You can safely stop it. Less than 3 mm, yes, he is not allergic and is ruled out. Between 3 to 8 mm, you need to do a challenge. Or if that patient is eating that particular food and is comfortable, then you just can continue with it. Please do not go by the test. Same thing goes by the specific IgE. The specific IgE is very high, above a particular level, in a very high level for that particular type of testing, as in peanut out here, and hazelnut and pista more than 100, and cashew nut. You can safely stop it, and you need not do any particular testing for that. What I mean testing is challenge for that particular patient. But anything less than that, as in case of almond, the second one, 89.40, it's quite high, okay? But the child was taking almond freely. Take the red one, the milk, okay, 51, right? It's quite, almond 89, child tolerating very well, but 51 develop severe reaction. So you cannot go totally on this. Clinical reactivity is the most important thing in their diagnosis of food allergies. Next, please. So besides the skin prick test, and we have the new test known as the component resolved diagnosis, where we look at each component in the particular food, and it will also help us whether you'll develop anaphylaxis or not, whether you'll outgrow your allergy or not, whether you can enjoy the food in the cooked form, or whether your dust mite allergy will respond to treatment or not. So with this 3 ml of blood, we test 300 allergens. Next, please. So look, this was this case. Thansi, a 5-year-old child, okay, and 5 years, 9 months. And for cow's milk, she was positive, and it was 6 mm. With this component result diagnosis, and this is a report for milk for this particular patient. This child is positive for cow's milk, camel milk, goat milk, and sheep milk, right? If you look at cow's milk, it is more than 50. They are not testing beyond 50, okay? And she was reacting very significantly to cow's milk. The next thing is, how does it help is that casein is positive. So if casein is positive and highly positive, then you cannot have this child taking cow's milk. I mean, this child can develop anaphylaxis and will never outgrow the allergy. If the casein would have been negative and the other components would have been positive, then you could have given this child cow's milk in the boiled form. So now, what you can do in this, with this result, you can, after a challenge with mare's milk, that is donkey's milk, which is freely available in my part of the country, in Hyderabad, you can safely give mare's milk if the child really wants milk. Okay, so that is how this particular test can help you out. Okay, next please. Now this slide is very important. You see, how many of you, if I ask in a meeting, how many have you seen cases of cow's milk allergy? More than 2. 1 everybody will see, 2 you may see, but more than 2, hardly, very few. Maybe Jagdish Chinappa may have seen quite a few, but otherwise very few of us see cow's milk protein allergy in a clinical practice. The reason for that is, in infancy, the cow's milk protein allergy presentation may be very subtle, okay, very subtle. It could be as subtle as behavioral changes like hyperactivity or with diarrhea, constipation, or many of those children who are having reflux. You need to start looking for cow's milk protein allergy. Those who are having eczemas, you need to start looking for cow's milk protein allergy. It's not necessary that you will see that cow's milk protein allergy with a classical manifestation of urticaria and going into shock and with severe vomiting and wheezing and all. So the more you look for, I try to look specifically for cow's milk allergy in children, the more you might find out. And usually most of them beyond the age of 2-3 years, they outgrow. Next, please. So the second case, baby Harshita was formula fed at birth. On day 15, there are episodes of few small loose watery stools. Over 3 months, it persists with persistent motions requiring IV fluids, settle only with a protein-based formula. Motion recurred on reintroduction of milk, any form including the soy-based. But here the IgE to cow's milk was negative. So this is what it is. If your IgE, you do a blood test that is specific IgE for milk in whom you are suspecting, and it turns out to be negative, is in such case who present with severe watery stools, and it could be a non-IgE mediated cow's milk protein allergy, which we address as food protein induced enterocolitis syndrome. Okay, so you can do, what you have to do is to stop milk and then subsequently do a challenge. Next, please. Okay, a 2-month-old boy exclusively breastfed, given supplement bottle of cow's milk formula, and 4 hours later, in a 2 month, there are profuse vomiting and diarrhea, lethargy, and sepsis like picture, taken to the ER. Which diagnosis should be considered? So now, traditionally, if you look at it, if I was not an allergist, I mean a person interested in allergy, and I would put it in a non-allergy meat, everybody, you would always think of the first 3. That is, sepsis is a possibility, yes, because it had a sepsis like picture. Intussusception, yes. Volvulus, rare, but also can be thought of. But this case was a case of F-pies, okay? And this is a condition when, if you're sure this is not sepsis, not intussusception, not volvulus, think of F-pies and think of stopping cow's milk and see the response. And usually most of them will outgrow by age of 2 years. So this is the other point which I wanted to put across is, in the first year of life, children having severe diarrheas, think of cow's milk, and could be also think of F-pies, okay, which will show your specific IgE2 as negative. Next, please. Now, this is another interesting case. 7-year-old Neeta. Now, I'm sorry I put the caste because they were strict vegetarians. Okay, had rashes all over the body twice. The first was after eating veg Manchuria, and within 30 minutes they developed it. The second after ordering a vegetarian sandwich with mayonnaise. And the third attack after a cake with it was followed with severe difficulty in breathing and went into shock, anaphylaxis, and they had to be taken to a hospital where adrenaline was given along with Avil and hydrocortisone. And a CRD report. And next, please. So this is the CRD report. Okay, we for milk and all other allergens were negative. Milk was positive. Sorry, egg was positive. Egg white. 15. Okay, that is GAL-D-white. This is one of the component of egg, and yolk was also positive. And so what you see is the report where both egg white and egg yolk is positive, especially egg white. Now, if you look at the, they have never had a vegetarian meal non-veg meal at home, but this still has come positive. Egg white is a commonly used ingredient in many of the food components as an emulsifier. It helps to, the ladies out here will definitely know how egg white helps. It acts as an emulsifier of holding two different surfaces together. Okay. There's another component called lecithin. Lecithin is derived from soy. It can also derive from egg. Okay, and this is commonly used in capsules. It's a commonly used component in medicines. Then you have your egg shampoos. Okay, and a lot of cosmetics where egg may be an ingredient. So normally, even if you're strictly a vegetarian, you are constantly exposed to this small quantities of egg. Okay, so the common question the patient would ask me is, why did it happen now? Why did it not happen earlier? So it's obviously you're gradually being sensitized, and जैसे हिंदी में कहते हैं पानी ऊपर आ गया. So then the water has come up and it reached that critical point that the child manifests with this symptoms of allergy on taking that particular quantity of egg. And then every time after once the child gets an allergy to that particular food, every time he's exposed to that particular food, yes, he will get it. And each time it could be more severe, as in this particular case, that first time it was just 2 episodes of urticaria and third time landed up in anaphylaxis. So next, please. Now, 6-year-old male child came with recurrent urticaria, was suffering for the past 4 years, response to antihistamine steroids, and parents noticed that after taking chana dal and green gram, the urticaria worsens. We did for the lentils, it came 10 millimeters. After stopping all lentils, his condition is better. So lentil is also, the dals, pulses are very important thing. They can present as recurrent urticarias. Okay, it could be very a mild form, and but then when once you diagnose the dal, then someone's thing is on. Just be careful. I hear some background noise. So you have to think of protein protein malnutrition, and you have to give him good protein supplements. Next, please. Now, this is a very common case which everybody in your practice will see it. A mother gets a 5-year-old son with repeated nasal congestion and cough. She says that this cold is aggravated with banana fruit. A prick-to-prick test with banana and a specific IgE blood test of banana is negative. So, the other thing, the finding was there is no rash, there is no itching, there is no swelling, and there are no gastrointestinal symptoms. So the question is, why is it occurring? And what should I do when the parent comes to me with these symptoms that gets aggravated with fruits, with orange, or with banana? A very important thing is the last line is important. If there's no rash, there is no itching, there is no swelling, and there are no gastrointestinal symptoms, please do not think of fruit allergy in that particular case of rhinitis or asthma, because if it is a fruit allergy, maybe banana or orange, then there would at least be some rash or itching or some swelling or some GI symptoms. And if you have a doubt, you can get the specific IgE done or the prick-to-prick test done and confirm it with the on testing. But then the question is, why is it occurring? So very simple. That is the sticky thing, and usually this orange fruits and all citrus fruits have a lot of histamine. That is what that histamine causes, that irritation out there. While banana has an enzyme which prevents the breakdown of histamine, and because of that, it is the histamine in the banana, in the high histamine, which will cause the irritation out there. So what happens in these patients of rhinitis and all, chronic rhinitis, the mucosa is denuded, okay, this is inflamed. So when this inflamed mucosa is exposed to these chemicals, okay, same thing as when exposed to cold water, it gets aggravated. It is like applying chili on an abraded skin. If you apply chili on a normal skin, nothing will happen. But if it is an abraded skin, it burns. So same thing, it burns and becomes worsened. Or what we say in English is adding insult to injury. So what is the solution? The solution is what in that tradition has been, that banana chart. Many of them, if they have banana chart, okay, with this salt and pepper and chili added to it, nothing might happen, okay. Or if you take banana in the cooked form, or the banana chips, nothing will happen because that chemical is broken down. Next, please. This is another very common scenarios you see. A 14-year-old boy with history of wheeze in childhood. He developed articular rash and swelling of the lips on ordering Hyderabadi biryani from a takeaway. He responded to emergency treatment in the ER. History of similar but mild episodes in past on that takeaway biryani. No such episodes on home cooked biryani. So when a patient comes to me, so they might attribute it to the biryani or the rice or to the chicken or to the mutton in the biryani. Okay, it could be any component of that biryani which could be of that particular food, which could be causing it, including the spices. It could be fenugreek, that is methi seeds. It could be ginger, anything. It can be in that particular. So you have to get the full ingredients of that particular food which is present, and you have to test him for each component. Now we tested for each component and everything was negative. Then why did this child develop this rash? The reason is very simple. It's the colorants. In home you don't add colorants. Outside a lot of colorants are added, and there are many colorants in the market, and it is these colorants in these patients who are prone to develop allergies, who have asthma and all, who are more likely to respond to this colorants and get articular rash. They may not get they may not get anaphylaxis, but every time they will get this articular rash. There are very rare colorants which are derived from an organic matter, which can sometimes lead to anaphylaxis. But generally, anaphylaxis occurring in these patients secondary to colorants is not known. So the answer would be stop eating any food from outside, stop taking all food, adding any colorants to the food. In short, a good habit would be stop all processed foods, all outside foods would be the blind advice to these patients. Next, please. So what are the common foods causing allergies in children age-wise? I've discussed with you. When do you suspect the child with food allergy? I have presented different case scenarios and how to go about in those case scenarios. Then the last question is, what are the other manifestations of IgE mediated food allergies? Next, please. So we have cutaneous food atopic eczema, generally begins in early infancy, characterized by a typical distribution, pruritic, extreme pruritus, and chronic relapsing course. Allergen-specific IgE antibodies, which are bound to Langerhans cells, play a unique role as non-traditional receptors. Double-blind food challenges need to be done. Food allergy as aggravating in atopic dermatitis would be, as I mentioned, 35%. Next, please. Acute urticaria and angioedema, the most common symptoms of food allergic reactions. Exact prevalence of these reactions is unknown, and acute urticaria due to contact with food is also common. Chronic urticaria is causing chronic urticaria angioedema is very rare. Next, please. Asthma, uncommon manifestation, usually seen with other food-induced symptoms. Vapors or steam emitted from cooking food induce asthmatic reactions. Food-induced asthmatic symptoms suspected in patients with refractory asthma and history of. So if a patient of asthma goes into an anaphylaxis, or no, becomes very severe, you should investigate for food allergy, that particular food may have worsened it. Rhinoconjunctivitis, very uncommon. Next, please. So IgE mediated systemic reaction anaphylaxis, food-induced anaphylaxis is rapid onset, multi-organ system involvement, potentially fatal. Any food is, especially it is for peanut, nuts, seafood, milk and egg. Then we have food-dependent exercise-induced. Most commonly, it is wheat. Next, please. So the mainstay of treatment is avoidance, must be considered as a therapeutic approach. Risk-benefit must be assessed. Correct diagnosis is essential. And unnecessary restriction, blind restrictions will lead to malnutrition, and the dietitian role is crucial. Next, please. So vitamins and minerals which will be affected by restricted diet in milk, egg, soy, wheat and peanut. I mentioned the different vitamins and minerals which could lead to deficiency, and if the patient has that particular allergy or that particular food, then those vitamins should be replaced. Next, please. So the important thing is follow-up. Reevaluate for tolerance periodically. How often you should do the challenge, it depends on the type of food allergy. Okay, the severity of previous symptoms. If it was very severe, then I wouldn't dare to re-challenge. And also on the allergen. If it's going to be nuts, tree nuts, peanuts, seafood, it's very unlikely to outgrow. I would not bother. If it is milk, yes, I will do it every 2 to 5 years. Okay. As vegetables, yes, I will do it often. And the testing which is there, the skin prick test, the component resolved diagnosis, 2 cases which I have shown to you, and what is available right now all across the country is, which you're doing is the CAP, okay, or the immunocap. That is by the FAI method with Thermo Fisher is having it. Next, please. So, do dietary restrictions prevent food allergies? How can doctors help prevent their patients getting food allergies? And this is a very important last message which I want to give across. So, next, please. Now, I would say with this is the LEAP study results, which is from Germany, learning early about peanut allergy, where they took 600 children aged between 4 to 11 months who had a high risk for peanut allergy because of the family history. So they were divided into 2 groups. One group was made to consume peanut containing snack food 3 times in a week from the age of 4 to 11 months. The other was made to avoid peanuts. In the one which was made to consume peanuts, 3% developed peanut allergy, and the one which was made to avoid peanut, 17% developed peanut allergy at the age of 5 years. So if you go back to our tradition, to our lifestyle, in India, across cultures, okay, all throughout, we have that Anna Prasadam, where around the age of 5 to 6 months, you start introducing traditional diet containing carbohydrates and proteins. Okay, it's been a custom, okay, across the country to introduce that. Okay, so we were gradually exposed to this a protein-based diet and a carbohydrate diet and a home-based diet from as early as 6 months of age. While in the Western society, what they did was, especially because of the policies of the American Academy of Pediatrics on when to introduce peanuts and when to introduce protein materials early in the 90s and all, and the early part of the 20th century, they said late introduction of protein stuff because it will cause allergies and all. Okay, if you introduce early, and now they have gone back and now they say what we have been doing for centuries is early introduction of protein-based diet as early as possible, and a traditional, and I would add one more important thing to it, a traditional based diet, not your processed food, not your tin food, not your canned food, but strictly processed, strictly a home-based diet, which should be given to the children. It could be of peanuts, it could be of around 7 to 8 months egg. Okay, the earlier you start introducing protein-based formulas and a home-based formula, the better protection you will be giving to the kids and preventing food allergies. It's a tough job, but that's what is needed. Next, please. So, IgE and non-IgE mediated food allergy conditions exist. History and examination are paramount. Diagnosis by elimination and challenge testing. Avoidance, education, preparation for emergencies are current therapies. I have not discussed because earlier I had given a lecture in Baroda itself on the web and I discussed anaphylaxis. So that's why I did not go with it this time. Periodic re-challenge to monitor tolerance as indicated by history, allergen, and level of food-specific IgE. Next, please. So I thank this is for anyone who wants more information. This is my book, Winning Over Allergies, is available on Amazon. I'm coming up very soon with the next book, Overcoming Food Allergies, where predominantly we're talking about this processed food and junk foods and all besides your management of food allergies. It's for both parents as well as for doctors. Next, please. With this, I thank you all. That's my website. And next, please. So next. Sorry. Next. Oh, yeah. This was the last one. This was the case which we had given on this one, and Dr. Jagdish Chinapa was very right that C1 estrase inhibitor deficiency. Yes, I agree with him. But then I have a lot of patients who we do C1 estrase inhibitor. This one, it comes negative. In this one, it was positive. Similar one, C1 estrase is negative. We do food allergy, it comes negative, and then we don't know what it is. So it is open to discussion what we should do in such scenarios. Thank you, one.
Thank you, Dr. Arif. Wonderful talk. I could partially hear you all through my journey from
Can you shut it out?
So
take that girl out from there.
Yeah.
Take that picture out.
Stop the screen sharing.
Stop this then. Okay.
Yes. So wonderful. You could manage the slides so well with help of Dr. Chitra. Thank you, Chitra. Now the house is open for discussion and question answers and comments.
Thank you, Dr. Arif. Wonderful talk as usual. I think we are now seeing a spate of increase in allergies all over in all populations and in all different systems of the body. So thank you very much for that wonderful talk on food allergies. And I only hope that the cost of allergy testing comes down, because with such a high prevalence of allergies, the cost of doing a component analysis is close to some 18,000 or 20,000.
No, 15,000 my place.
Whatever. It's beyond the normal affordability of most patients, for allergy testing. So I think it's a wonderful thing, an upcoming field, and very nicely spoken by Arif. Thank you very much.
But the discussion is open regarding that case. What do you do? Because I myself is clueless. So C1 estrase is a very important thing we have to think of. But food as a cause of that is very rare. Okay, so then after all, both come negative. If the house is open to is your opinion, what do you do then? I have no solutions to it.
We have had a couple of patients with C1 estrase deficiency, and we can only manage them during episodes. We cannot do anything to prevent it, because there is very little that you can do to prevent. Sometimes, I don't know how, this is anecdotal, cyproheptadine may be used. I don't know whether it makes
no. But Jagdish, my question different. The other thing what I discussed with the immunologist from your town is, if your patient comes like this and C1 estrase deficiency is normal, that test is normal, and you still strongly suspect C1 estrase deficiency, then when the episode occurs, the swelling occurs, you need to do a C4 level at that particular time and check for it, because in between episode, the C1 estrus test may be negative.
True, agreed. So the other thing which you can do is now you can take the help of the genetic screening, because sometimes you can pick up the genetic pathway to C1 estrase inhibitor deficiency. So I think that's another way we can look at it.
Okay.
So I'm going to leave now. Thank you very much, Arif, and thank you, Chitra. Thank you, Satish Bhai, and thank you all of you for a wonderful discussion. I have to catch the flight to Baroda, so I better leave now.
Okay, thank you, Dr. Jagdish. There's a question out there. What is the full form of CAP, immunocap? This is that Thermo Fisher. They do this test which is known as immunocap. Okay, the full form is I don't know what is the full form of CAP, but it is by the FEI method, fluorescent enzyme immunoassay. Okay, and they have labeled that as immunocap. So it's not important what I mean.
It's a brand. It's a brand.
The brand is a branding. Correct. You're right, Satish.
He has also
Which blood test do you suggest, ELISA or Cardiotop? ELISA is there. It's a very important. This is a good point. Okay, now when you are testing, you should ask the particular laboratory to have it by FEI method, fluorescent enzyme immunoassay method. That is FEI method should be what it should be, because ELISA is outdated. Okay, the fluorescent enzyme is the most important one and more reliable. Sir, can you tell us how you reintroduce food? Okay. Now, the best part was feeding idea to infants, toddlers with small amounts of varied proteins food at the earliest by mothers to prevent food allergy. Later, avoid processed canned foods, but they like cereal, like kids eat fast, so caregivers give it when mothers are away. Yes, very true. All of us, like that Parle-G biscuits. Remember, as we love Parle-G biscuits, and that's what mothers give to kids, Parle-G biscuits. Yes, Dr. Satish.
Yeah, very true.
But have you ever looked into the content of the Parle-G biscuits? If you look into the content of the Parle-G biscuits, you'll stop giving in detail what is there in that Parle-G biscuit. You'll stop giving to your children. Okay, I mean they have this. The Parle-G biscuit is preserved for 2 years. You can imagine what amount of if all those preservatives were not, and you keep your food outside for 1 day and it'll catch fungus. So you can imagine what things must be added in that Parle-G biscuits so that it doesn't catch fungus. So that's what I want to point out is, please look into the contents of the Parle-G biscuits and you'll think twice before giving to your infant child, okay, about this Parle-G biscuit, because we know as children, we love to dip it in tea and enjoy it, but it is not just good for your health, okay? I know kids like it, but then if you want to prevent food allergies, give them as natural food as possible. Is immunotherapy helpful? It has been proved only for peanuts. That is the recommended thing. In India, we are trying. Peanut is the only thing which is being tried. Okay. What is the importance of in vitro allergen testing done by some reference labs? Yeah, this is a point. When you get it done, see that it is by FEI method. The new one, that is the which I showed through my presentation, CRD, component resolved diagnosis, is very costly. I charge 15,000. Some labs are charging 20,000 for the same 300 allergens. Okay, there is a price thing going on. Okay, we do it at the least possible profit. That is a very reliable and a very good test with a lot of with hardly any false positive. Okay, so that's what I would suggest. Now, the first question: can you tell us how to reintroduce food? Okay, I did mention in my talk, if you're going to have nuts, peanut, tree nuts, seafood, or egg, do not try to reintroduce. Okay. If it is milk, yes, you can reintroduce. How do you reintroduce? It's a very simple thing. If it had not had a severe reaction in the past, you can reintroduce. If it had a severe reaction, then again you have to do a home hospital challenge. The easiest and the best way is to start with the baked products, in which the milk may be in a very little form, like your biscuits, milk biscuits. Okay, a small amount of milk biscuit, and then in my next book, I have put how to do this challenge, and there are definite way of doing it. Okay, every 15 minutes, you start with the minutest quantity, and every 15 minutes, you double it. So first you start with the biscuits, then after the biscuits, you will get on to other milk products and all, like your cheese and or butter, and in the end, you'll go for boiled milk, and if that also is okay, then last you will go for non-boiled milk. So first you start with the milk products like biscuits and cake, and this is most for milk only. I wouldn't dare to challenge anybody with try to reintroduce peanuts. And the other thing is, if they're so concerned, get this component result diagnosis. Okay, if the component result diagnosis will really help you, whether you can, if the stable allergen has been positive, that means this child will never outgrow the allergy, and therefore please do not try to re-challenge this particular food with that patient. I hope I have answered his question. Because CRD, component result diagnosis, will help to help you whether you can re-challenge or not re-challenge. Yes, Dr. Pandya.
Yeah, my question is regarding parents ask for Patanjali products, because when we say don't give biscuits, their query is about Patanjali, whether they are safe or not. But when I read the contents of Patanjali products, they do also have these preservatives. So my answer is usually no. So what is your take on that?
Yeah. See, the thing is, all foods with preservatives additives, they have been sanctioned by FSSI, that is a recommending body, to have it in a certain quantity. Okay. Now we do not have good monitoring agencies which are seeing whether those preservatives additives are within the permissible limit or not. We do not, in India, we do not have that. So, especially if there are doubts about food allergies, about reactions, please avoid all processed food, all outside food. Otherwise, if there are no such doubts, they can take it. That's what I would say.
Yeah, my other comment was regarding the question which was asked about reference laboratories doing those tests. What probably the questioner meant was those large number of allergens they test for 1,200 or 1,500 rupees with food allergens, environmental allergens. I think these are not IgE specific tests.
Yeah, no,
that is to be discouraged.
That's why I mentioned very clearly, when the report comes to me, okay, I'll have a patient with so many allergens tested, okay, and with some advertisement in newspaper, they went and got it done. I first see the method. If the method is not FEIA, I throw it in the garbage. I said I'm not going to look at it. That's all your approach has to be. Look at the method. One is the method. Second is whether from a standard laboratory or not. Okay. So, and obviously if it is, mine may not be a standard laboratory, but then whether a pathologist or MD or qualified has signed it or not. Okay. Look at these important things. These are two important things. First, the method, and then being signed by this one. But if you know it is from I know some reputed labs also who are doing this IgG test, okay, for food intolerance. They also should not be looked at. Okay, they are just a waste. There's nothing like IgG test. Has no role in diagnosing of food allergies. Okay, now I'll have this parents ask, in adults we get eosinophilic esophagitis supported by a high eosinophil count. So is it so for in toddlers? Well, eosinophilic esophagitis is seen in children, but I have not seen it, so I would not be able to say much about it. People who are allergic to wheat and not allergic to bajra, if they start bajra, they develop food allergy. What could be the reason? Well, I have not come across such cases and all, because wheat is different, millets are different. Okay. So I would like to show, and that's what I said, the Baroda crowd is very enlightened. So if there is such a case where wheat allergy was there, and then he started bajra and developed allergy to bajra, then I would definitely like to like Dr. Mistry to share that what exactly that case was, because I cannot comment on this. Very unusual. So which are the common food allergens you found in your area for Indian-born children? Well, the commonest is the milk allergy, which is all around. Okay, is the commonest. Now we are seeing a lot of allergy to sesame. This is what is you have to look at, sesame. Okay, and because of the wide use of eggs and all, egg allergy is also becoming very, very common. That's it. I don't see much of peanut allergy. Peanut allergy is more in the West. One reason I said is because of the delayed introduction of peanut in the West, and two is the way they have the peanuts. In the West, the peanut is had in the roasted form. Okay, in India, in the entire Orient, China, India, and all, we take it in the boiled form. The roasted form is more allergenic. The boiled form is less allergenic.
Dr. Arif, you talked about challenging for milk allergy with biscuits containing milk. So why not milk directly?
Yeah.
Small amount.
Well, then you be ready for a catastrophe if possible.
So the biscuits contain very minuscule quantity.
Yeah, minuscule quantity and in the very cooked form, where much of that has been broken down. So that's how you gradually check.
Okay.
Dr. Arif.
Yes.
Dr. Sant, in Ayurveda, they say that ghee is different than butter. Butter is different than buttermilk. And cow, buffalo, and goat milk are different.
Yes.
So there must be some molecular basis of it. Let's find out.
Yes.
Another thing is regarding bajra. Bajra is used by us for gluten-free diet. But if you roast the bajra, or there is a fungus over bajra, which might get the food allergy. That is my experience as a GI endoscopist for 30 years.
Okay, good. Now I get to the point. You know better on this bajra, so that it is whether it is those patients, whether we did the prick test for bajra or not, that is important. And if the prick test comes positive, then only I would say yes, because if it is the fungus causing it, then it's a different thing. Now your first point which you said is about the milk. I have shown you through my case that was positive for all the milk except for mare's milk, that is donkey's milk or horse's milk. Now what is so special about donkey's milk? The donkey's milk is the nearest to the human milk, to the human milk. What is so the other thing is, like human milk, what is it that causes allergy in milk? It is the casein. The donkey's milk has the lowest content of casein. Human milk also low in casein. Well, buffalo milk has the highest amount of casein. Okay.
Wonderful.
Okay. So while the donkey's milk has the lowest amount of casein, and the casein which is causes the anaphylaxis. And casein is there's a lot of talk also about ADHD, not ADHD, autism and ADHD hyperactivity, casein causing hyperactivity, and in children having hyperactivity, giving them casein-free milk or donkey's milk or cow's milk. And a lot of children in anecdotal studies and presentations have shown benefit to the hyperactivity has come down when they have been taken off cow's milk or buffalo's milk and put on camel's or goat's milk. So the answer to your question is the casein content, and use milk with the lowest casein content, and that is donkey's milk if it is not showing any clinical reactivity.
That was very informative. I mean, donkey's milk closest to human milk means that we should stop using donkey as a swear word.
Yeah, I mean, in my part of the country, in the rural Telangana, donkey's milk is very commonly used, and in the Middle East, camel milk is very commonly used. They don't have cows and buffaloes; they have camels, and they use camel milk very often.
Some communities use goat milk. How about that?
Well, goat's milk also is very good. Okay, but if the child is not, but the children may not like the taste. That's the problem.
It's exactly 1 minute past 9, and if there are no questions, we can end the session here. Thank you so much, Dr. Arif, for joining us on Saturday Club meeting, and surely we'll have you again and again in future.
I'm very glad to be with you, and I'll learn about this Bajra and new things and all. Okay.
So thank you all for
Thank
joining.
you all.
For joining this Saturday Club meeting. Next Saturday we meet again at 8 a.m. Thank you all. We
Thank
end
you.
it.
Bye.
Thank you, Dr. Arif. Thank you. Thank you, Chitra.